I think we're going to get started. So hello, everyone, and thank you so much for joining us for this fourth Refresher Vaccinology webinar series. For those of you who have been attending the past webinars, we've had very good and engaging sessions, and we welcome you to this fourth webinar session, and very glad that you've joined us. Just a quick introduction into this webinar series. So it is hosted by myself, Dr. Benjamin Kagena, with Professor Rutani and Professor Greg Hasse, all based at VACVA, which is within the School of Public Health at the University of Cape Town. Just a quick background. We have been running vaccinology course for the last 15, 16 years, as early as 2005. These are the aims of the course, which I'm not going to speak to in details, but this is the people that have attended the past vaccinology courses, immunization program managers, researchers, and also postgraduate students. And below are some of the sessions that are covered in this vaccinology courses that we host. It's a 5-day, and thankfully, after stopping in 2021 because of COVID, thankfully we're back. We are engaging with partners to ensure that we're able to resume with face-to-face vaccinology course in November. So keep an eye on our website, and normally we send our alumni and circulate the call to attend this vaccinology course widely, and we post it on our website. So have a look at our website. Just a bit of background as to why we're hosting this webinar series. So the first thing that we did was to do a quick survey to look at the need for refresher training by those who have attended the vaccinology course. And we have had about 1,000 people who have attended this VACVA's vaccinology course for a period of 16 years. And we managed to send questionnaires to about 100 people and ask them whether there was need for them to do refresher vaccinology training. And we did this because year and year on, when we receive the applications, we see quite a bit of interest of people who have been trained in the past wanting to come again. So it was the reason that we said, okay, let's see whether there is a way we can address this need of people wanting to come back. And given that virtual training has become very, very common during this period of COVID, we thought vaccinology webinar series could be helpful to fill this gap. So most of the participants said that the reason that they would want to do vaccinology refresher training is to stay up to date, to refresh and to reinforce, and also to do networking. And this webinar series is primarily focused to address those reasons that were raised by the alumni during the survey. So the aim of this refresher vaccinology webinar are to provide an up-to-date information on the current and emerging trends in vaccinology, give some refresh on some key vaccinology concepts. We do understand vaccinology is very broad, so we I thought what could be some of the key vaccinology concepts that could be covered, and we were able to identify some of the emerging themes that could be discussed. And also we wanted to create a forum for networking among AAVC or Annual African Vaccinology Course alumni. And the idea behind this is that we keeping in contact with alumni and also those who are not alumni and attending this webinar series. Because you've registered, we're going to create a mechanism that we can be a community that can exchange ideas and talk and, discuss the challenges and potential solutions to what we are facing in our different countries. So the next slide talks into the agenda for today's webinar. So I've done the welcome and I've mentioned about the objectives. So we've got 4 speakers, and these are their 3 speakers, sorry, and these are their topics. We've got Sarah, we've got Carolina, and we've got Cheryl. And then we've got a moderator, who is Charles, who is going to chair the discussion session during Q&A. And then we'll close the meeting. So just to request the speakers to first thank you for making yourself available to give these talks. And also to say that when you start the presentation, please take 1 minute to introduce yourself. And then you can carry on with the talk. And once you finish, then the next speaker comes in and introduce themselves, herself, Carolina in this case, for a minute, and then hand over to Cheryl. And then Charles will take over from there. And then just a bit of housekeeping. There is a Q&A chat box that we request you to send your questions. And then during the moderated discussion session, the speakers are going to be addressing your questions. And Nena and the team are going to be collating these questions and project them on PowerPoint so that the moderator can see the questions that are posted on the chat box. And please remember not to post the question on the chat. It's Q&A, because if you post it on the chat box, even as we cannot copy and paste it on Q&A, because the way the webinar platform works, we do not have the right to copy and paste on there. Without further ado, I'm going to hand over to the first speaker, who is Sarah Cooper. Sarah, over to you, and thank you.
Thanks very much, Ben, and thanks and welcome everyone. So yes, my name is Dr. Sarah Cooper. I am a senior scientist in Cochrane, South Africa at the South African Medical Research Council. My background, I'm a social scientist, specifically a medical sociologist. And over the last 4 or 5 years or so, my focus has really been on the social and behavioral drivers of vaccination uptake and hesitancy and acceptance. So, Salim, are you going to share my slides? Do you want to maybe put it on slide view? Brilliant. Thanks so much. So I'm going to be speaking on the topic of strategies to improve demand for vaccination and increase vaccine confidence with a specific focus. Sorry, for some reason my camera's just gone off. Sorry, there we go, with a specific focus on COVID-19 vaccination. Next slide, dear. So I've divided this presentation into kind of 2 main parts. In the first part, I'm going to really introduce some of the studies that myself and colleagues have conducted on COVID-19 vaccine hesitancy and confidence in South Africa, and particularly focus here to highlight some of the key insights we've gained from these studies about the nature and drivers of vaccine hesitancy and confidence. It's very difficult to talk about strategies to reduce hesitancy and increase confidence without a kind of little understanding of some of the drivers of these. So that the first part of my presentation will focus on that, giving that sort of context. And then in the second part of my presentation, I'll propose various strategies for reducing hesitancy and increasing confidence and demand, specifically for COVID-19 vaccination. And here I'll draw on some of the insights we've really gained from our own research and also some sort of recently published resources on strategies in this area. Next slide, yeah. So over the last 2 years or so, more now, myself and colleagues at Cochrane South Africa have been involved in various studies exploring the prevalence, nature, and drivers of COVID-19 vaccine hesitancy and confidence, specifically in the South African context. So, for example, as part of our work with the National Department of Health Technical Working Group on COVID-19 vaccine hesitancy, we led a rapid review of surveys that have been conducted in South Africa investigating actual or anticipated acceptance of COVID-19 vaccines. And on the slide are some of the various references to this review we conducted. Next slide. So the aim of the review was really to gain a better understanding of COVID-19 vaccine hesitancy and acceptance in South Africa, really to inform the development of relevant and appropriately targeted strategies to address it in the country. So we identified and included 12 surveys. This was conducted on or before the 31st of July 2021. And the sample sizes ranged from 400 to 75,000 participants. And most surveys, 10 of them included nationally representative samples. Next slide. Yeah. In addition to this, at the start of COVID-19 vaccine rollout in South Africa, we also implemented the vaccine study. And this was really a ward-based mixed method study, which had two kind of primary aims. Firstly, to explore the barriers and facilitators to vaccine acceptance at a ward level. And then secondly, to investigate what strategies might be appropriate for addressing vaccine hesitancy and improving uptake in these settings. The study we implemented in 4 diverse settings, including urban and rural settings across 3 provinces in South Africa. Next slide. In a very brief nutshell, in terms of the methodology, we employed a mixed methods multi-case study design that was informed by a socio-ecological model of behavior change. And the study involved kind of 3 iterative phases, including exploring community experiences of COVID-19 in phase 1, in phase 2, exploring the extent and drivers of COVID-19 acceptance and hesitancy, and in phase 2, synthesizing and disseminating the findings. Next slide. In addition to these studies, we've also conducted a cross-sectional survey amongst healthcare workers in Cape Town to assess willingness to accept COVID-19 vaccines and also predictors of vaccination intentions. And then finally, at the moment, we're currently conducting a large qualitative study, including observations and in-depth interviews, exploring vaccine acceptance, hesitancy, refusal, specifically COVID-19 vaccine hesitancy and refusal amongst healthcare workers and also people living with non-communicable diseases in South Africa. Next slide. Yeah. So what have been some of the sort of overarching insights from these different studies that we've gained about the nature and drivers of COVID-19 vaccine hesitancy and confidence in South Africa? I think one of the most consistent findings across our studies has really been the considerable amount of fear and anxiety people have about the safety and effectiveness of the vaccines. So many people spoke about sort of their concerns about the novelty of the vaccines, their concerns that the vaccines have been developed and tested and approved in such a short space of time, really compared to other vaccines. And some of their concerns were also that the vaccines are being manufactured using entirely new platforms. And so for many people, these concerns really raised questions for them about the safety and effectiveness of the vaccines. And we found that these concerns were being driven or at least exacerbated by kind of two main issues. So firstly, the very real uncertainty surrounding the pandemic. So since the beginning, the pandemic has been characterized by rapidly changing and evolving evidence, by new and emergent strains of the virus, and a constantly kind of changing landscape of travel bans and lockdowns. So for example, in terms of the evidence, there have been changes in our understanding about the virus and how it's spread, changes in what we know about what the vaccines can and can't prevent, about the duration of immunity offered by the vaccines. And so all this kind of uncertainty surrounding the pandemic, we have found has generated quite understandably, a huge amount of fear and anxiety and confusion for many people. We've also found that this confusion and fear has been driven or exacerbated by the kind of explosion of information that has surrounded the pandemic and COVID-19 vaccines. So these vaccines have really been sucked into a kind of vortex of confusing and often contradictory messages and various forms of mis- and disinformation, or what is now commonly called this kind of infodemic. And so we found that this has also contributed to kind of considerable amounts of fear and confusion about the safety and effectiveness of the vaccines that we just haven't experienced to the same extent with other vaccines. That said, another key insight we've gained from our research is that COVID-19 vaccine hesitancy is really driven by additional and more complex dimensions beyond misinformation. So in other words, our research has really shown how vaccine hesitancy has many possible root causes, which are not knowledge or information related. Next slide. So this kind of relates to our third key insight we've gained, and that is really that vaccine hesitancy is an inherently social process. So in other words, it's kind of deeply embedded in the wider social worlds in which people live. And we found many complex social factors are influencing views and practices around COVID-19 vaccination. So for example, we found age to be an important correlate of vaccine attitudes, with younger adults having more concerns and being less accepting. We found race and urbanicity as significant factors, with particularly white adults and those living in more rural areas being less accepting of the vaccine than other groups. We've also found how experiences of marginalization can also provide a sort of fertile ground for vaccine hesitancy. So with all the lockdowns and restrictions, the pandemic has really generated and exacerbated poverty, food insecurity, lack of social support, unemployment, and really a real sense of hopelessness for so many communities in South Africa. And what we've found is that amongst other important issues, this has also been a driver of COVID-19 vaccine hesitancy. So some individuals and communities really feel resentful being asked to vaccinate when so many of their other needs and concerns are being neglected. This context also fueled mistrust and loss of confidence that those in power have their best interest at heart. And so in other words, the kind of wider economic consequences of the pandemic are also playing out in some ways in relation to vaccine acceptance. We've also found how the geopolitics surrounding COVID-19 and COVID-19 vaccines is an additional kind of driver of vaccine hesitancy in South Africa. So in particular, issues around persistent vaccine nationalism, donor dependency, patent laws, and so forth have really all produced horrendous inequities in COVID-19 vaccine access between the global north and many African countries. And all of this is occurring against the background of a long history of colonial medical research, exploitation, and also more recent incidences, such as in the case of HIV/AIDS, where African communities were denied access to the very drug treatments which were tested on them as research participants. And so we found that these kind of politics surrounding the pandemic and vaccines is also perpetuating a kind of resistance to and distrust of COVID-19 vaccines and those delivering them. Next slide here. So against this backdrop, one can in many ways kind of understand the sort of sentiments that are being depicted in these images on the slide, where different communities in South Africa and many other African countries are feeling resistance to COVID-19 vaccine trials and research and the vaccines. Next slide here. So a final key insight we've gained about the nature and drivers of COVID-19 vaccine hesitancy and confidence from our research is really the big role of access and supply related issues. So we found, in other words, that sort of challenges around accessing vaccination and logistical issues related to vaccination services are also really contributing to vaccine hesitancy. So, for example, practical questions of geography and transport costs to get to vaccination services has been a real issue for many people in our research. The long queues at vaccination services and also the various issues around the online registration system have been additional factors kind of reducing people's willingness to go for the vaccine. So in other words, we found that the so-called sort of demand-related issues and supply or access-related issues are very interlinked and play out with each other. Next slide here. So with all of this said, the question then is, how might we address these issues so as to prevent and also reduce further hesitancy and increase confidence and demand for COVID-19 vaccination? I'm going to propose several strategies. These strategies are informed by the insights we've gained from our own research in this area and which I've just highlighted now. And my recommendations also draw on a number of the recently published resources on strategies to improve demand for COVID-19 vaccine and to increase confidence. And these resources are all displayed on the slide here. Next slide here. So it's important to emphasize really strongly how no single or one-size-fits-all strategy is likely to reduce vaccine hesitancy and increase confidence. As I've hopefully been demonstrating, vaccine hesitancy and confidence are really complex issues and influenced by many diverse and particularly contextually situated factors. So for this reason, really multi-component and targeted approaches are needed that address these multiple levels of influence. Such approaches really need to be tailored to local socio-political contexts, and they need to target the specific kind of concerns and value systems in those contexts. So this really does require, first and foremost, before anything else, an in-depth understanding of the kind of specific nature and drivers of vaccine hesitancy in particular contexts and amongst particular population groups, and then tailoring the development and implementation of interventions accordingly. That said, various broad strategies are being recommended and implemented in many different kinds of settings in an attempt to reduce hesitancy and increase confidence and demand for COVID-19 vaccines. So the first, one of the key strategies that's been found in various settings to promote acceptance of COVID-19 vaccines is really effective and meaningful communication, either as community level campaigns or within more individual patient healthcare worker encounters. And a number of different principles have been suggested around what effective and meaningful communication might look like. So firstly, it's really important to share factual information that people regard as trustworthy. And this includes, for example, information about how the vaccine was developed, its contents, effects and safety, background to the decision to recommend it, and also importantly, practical information about vaccination services. So the kind of where, how, who, when, and so forth. A second key principle of effective and meaningful communication, most particularly in the context of kind of one-to-one counseling, is really the issue of empathy. So research on COVID-19 vaccination and also routine vaccination more broadly really emphasizes the importance of empathy when interacting with those who may be vaccine hesitant or skeptical. And so this really involves listening to people's concerns in a kind of very non-judgmental way and being open to questions and to views that maybe aren't the same as our own. Various patient-centered specific techniques have been found to be effective here. So for example, something called motivational interviewing. And so training healthcare workers and other community workers in these kind of techniques could be very beneficial. Effective communication also really involves being honest about uncertainties. So here it's really important to provide balanced and transparent information, including about sort of potential adverse effects, benefit risk considerations, evidence gaps, and legitimate uncertainty surrounding the vaccines. So in other words, what's really being found is that overconfident declarations of vaccine safety and effectiveness in kind of absolute terms can actually undermine trust. Next slide. Another key principle of effective and meaningful communication is really the importance of using trusted messengers and mediums to deliver the messages. So kind of in different contexts and population groups, they may have different trusted messengers and preferred mediums. So it's really important to identify those and then to use these. Community engagement, participation, and ownership is really another essential component of effective communication that just can't be overstressed. So here it's really crucial to engage and form partnerships with community organizations. These groups are really close to their communities. They know how to tailor information to those communities. And possibly most importantly, they have trusted leaders who can be kind of effective spokesperson and mobilizers. So another really key aspect of community engagement is really leveraging trusted local leaders to engage with communities and act as kind of vaccine champions and advocates. And here it really is important to stress that many African countries have a rich history of community engagement and mobilization. So for example, in the context of HIV treatment literacy, and also the rollout of the Ebola vaccines in West Africa. And these examples could really be shared and lessons drawn upon for COVID-19 vaccines. It's also really important for communication strategies to use multiple accessible channels, both off and online, and including social media to deliver vaccine messages. Providing information in multiple local languages can also be very beneficial. And also, where possible, having platforms that involves some kind of feedback or interaction with community members. And then finally, communication strategies that contain positive social norm messages has really been found to be a powerful communication approach. This really involves emphasizing support for vaccination rather than sort of being punitive about non-vaccination. So some specific strategies here could include providing "I got vaccinated" stickers or badges at vaccination distribution sites, or encouraging people to text their friends and family or post on social media a kind of picture of themselves getting the vaccine. Or alternatively, having positive news stories about people seeking vaccination. These are all kind of positive social norm communication strategies. Next slide. Another really important strategy for reducing vaccine hesitancy and increasing confidence in the vaccines really involves targeting the structural and service level factors that may be hindering access and convenience. So many examples here. For example, providing vaccines through familiar and accessible locations could really help improve acceptance due to the kind of enhanced convenience and access in communities. Other approaches could include having vaccination outreach or mobile vaccination teams that really bring vaccination closer to where people live. So, for example, the picture on the slide here depicts our vaccine taxis that have been developed in South Africa and which drive to different communities and actually provide mobile COVID-19 vaccination. Another strategy could involve reducing out-of-pocket costs by providing people with transport money or food vouchers when coming for COVID-19 vaccination. This is another strategy we've done in South Africa. As depicted in the other picture on the slide, the Department of Health developed the Vuma vouchers, where people over 50 were given 100 Rand grocery vouchers when they came to get their COVID-19 vaccine. Other strategies could involve finding ways to reduce vaccination waiting times or making the logistical procedures people need to follow for COVID-19 vaccination really as simple as possible. So, for example, in South Africa, we've made the online registration and follow-up system simpler for people to understand and navigate when it became clear that the systems was too complicated for many people. Another really important strategy for reducing vaccine hesitancy and increasing confidence involves public ownership of COVID-19 vaccination more broadly, really through kind of public oversight and community engagement once again. So this could include, for example, actively seeking engagement with the public about vaccination services, listening to feedback and adapting accordingly. Establishing local public oversight committees could be another strategy, and also implementing bottom-up approaches for vaccination with community members. Next slide here. As also described earlier, acceptance of more targeted health promotion efforts like COVID-19 vaccination, particularly amongst more marginalized communities, really may depend on their other health and livelihood needs and concerns being met. And so here, sort of integrating COVID-19 vaccination with other primary healthcare and social development programs could really help to increase acceptance and reduce resistance, because this can help to really avoid the kind of exclusionary focus on COVID-19 vaccination. There's also a real need for advocacy and social mobilization around the geopolitics of COVID-19 vaccines. So here, initiatives such as the COVID-19 Vaccine Global Access or COVAX initiative are really important. And we need more of these, particularly kind of continental collective efforts coordinated, for example, through Africa CDC and the WHO Office for Africa. We also need advocacy for increased vaccine procurement and manufacturing on the continent. So too is the need for COVID-19 vaccine research and testing approaches that are more local and bottom up. So in other words, being led by African scientists and institutions and kind of anchored in locally responsive and relevant knowledge. So these kinds of initiatives really are essential to promote equitable and widespread access to vaccines, but they're also essential to kind of combat COVID-19 vaccine hesitancy and resistance on the continent. Next slide here. In order to respond to COVID-19 vaccine hesitancy, there's also a real need for ongoing monitoring and tracking of vaccine hesitancy trends. So this really will help to detect if and where pockets of vaccine hesitancy exist in a kind of timely manner, so that strategies can be developed before these kind of concerns intensify and spread. This kind of monitoring will also help facilitate the development of more targeted and evidence-informed interventions. And so this will also help to enhance the effectiveness and the cost efficiency of these interventions. Relatedly, broader and ongoing research is also needed. Research on vaccine hesitancy generally and specifically with regards to COVID-19 vaccine hesitancy in Africa is still scarce, and the evidence base is still heavily skewed to high-income countries. So there's a real need for more research in this area on our continent here. Specifically, there's a need for quantitative survey research, which investigates prevalence rates and determinants of COVID-19 vaccine hesitancy and acceptance, and also assesses the effectiveness of interventions. A number of survey tools have recently been developed in this regard to measure vaccine hesitancy. So, for example, the WHO's BEST and VHS tools, the 5C scale, amongst various other tools to measure vaccine hesitancy and confidence. So these tools, though, still most of them need to be tested and validated and potentially adapted for use in different settings in Africa. So that too is another really urgent area of research that's needed too. There's also a need for qualitative research in vaccine hesitancy and confidence to enable a kind of contextual understanding of the root causes and features and trajectories of these phenomena. And then finally, research into vaccine hesitancy really requires a multidisciplinary approach. As I've been showing, it's a very complex phenomenon. And so we need to build capacity in and draw on expertise from intellectual fields outside of the traditional scope of vaccination programs and research. So these include, for example, sociology, anthropology, psychology, education, communication, social marketing, amongst many, many other, particularly social science fields. So there's a lot to be done, I hope, is my main message that has come across. As a positive note, I think the pandemic really provides a unique opportunity to positively intervene in the growing trends of vaccine hesitancy more generally in our continent. The strategies I've proposed here, I think, if properly supported, have great potential to kind of bolster demand for and confidence in vaccines during and beyond the pandemic. Here, next slide. Yeah. I want to end with the words of Emily Harrison and Julia Wu. These scholars talk about how public confidence in vaccination programs really depend on the work these programs do for the community, socially, politically, morally, as well as biologically. And so they propose, once this particular epidemic has fallen into historical memory, the development of a vaccine for COVID-19 should not be the indicator of a successful response, nor should it indicate the achievement of an improved public health system. Vaccine confidence may be a better indicator. And I think this is a real motivator, at least I think, for why investing heavily in initiatives to build vaccine confidence is really so essential and urgent. Yeah. Next slide. Yeah. Thank you. And thanks for operating my slides, Salim.
Thank you, Sarah, for that excellent talk on vaccine hesitancy and the interventions that have been shown to work. I'm sure there will be many questions during the discussion session. And as I've mentioned on the chat, please, if you have a question or comment, just type it in the Q&A box. Next, we're going to have a talk by Carolina on digital technology for surveillance, reporting and response to VPDs. Over to you, Carolina.
Good afternoon, good morning, everyone. I'm Dr. Carolina Lanovaro. I work with the World Health Organization in Geneva. I am a medical epidemiologist, and before coming to Geneva, I used to work with the Regional Office for the Americas, so in PAHO, based in Washington, D.C., but working with all of the countries from Canada all the way down to Chile and Argentina. So I will be talking to you today about how digital technologies have helped us really with surveillance for VPDs, but also vaccine effectiveness studies and safety surveillance. So let me just put my slides on. 1 second, please. I hope you can see the slides all right. Is it visible?
Yeah, it is.
All right, so I put there my email in case you have follow-up questions. So let's start. We'll start really why we do surveillance, right? We do surveillance because we really want to understand the epidemiology and monitor trends in disease burden over time. And also how we are doing with some elimination goals, for example, polio or measles, and control of other vaccine preventable diseases. We really would like to identify outbreaks in a timely fashion so we can inform the response and ultimately prevention of future outbreaks. We would like to know how we're doing, so we want to evaluate our control measures. And there are issues with just monitoring our control measures in terms of vaccination using coverage. Coverage data is a different type of data. It's very problematic, particularly at fine levels. Trying to measure coverage in smaller areas, it becomes very difficult, relies on problems with denominators, etc. We also want to identify where are the immunity gaps so that we can take interventions to prevent the outbreaks, to close these immunity gaps. Ultimately, we want to inform public health planning and policy. And then surveillance data is really used as an input to many models to really understand the cost benefits and the effectiveness of and the efficiencies as well of our immunization programs. So I hope that I have convinced you with this slide that VPD surveillance is critical. It should be really an integral part of when we think about immunization programs. We have an immunization and immunization agenda 2030, which is our North Star or the goal. It sets the stage for the next, well, until 2030. So not next 10 years, but next 8 years. And many of the indicators here and the goals really relate to reducing the mortality and morbidity caused by vaccine preventable diseases. And not only in children, it's really important that the immunization agenda calls out the diseases that vaccines can prevent throughout the life course. Of course, it also focuses on equity and equitable access. We have impact goal indicators and then a strategic priority objective indicators. But importantly, we need vaccine preventable disease surveillance to measure how we're doing in reducing the mortality and morbidity from vaccine preventable diseases or VPDs. Here are the impact goals in the first one of preventing disease. Of course, we want to save lives, but we also want to control, eliminate, and eradicate some vaccine preventable diseases and reduce the outbreaks of vaccine preventable diseases. So how are we going to know if we're doing well getting to that goal? Well, we have to monitor the trends and we have to monitor how we're doing. And that's where surveillance along other monitoring elements become important. So we really need to, again, where are the outbreaks? And here is an example of, these are all examples, but just maps showing over time how things are going and for different vaccine preventable diseases. So how does surveillance work, right? I don't know if everybody's a clinician. If you are, I apologize. This is very brief, just to explain that a person gets sick and you suspect a disease, and then this is investigated. Ideally, you would take a specimen to do a diagnostic test, and then that specimen is tested in an adequate lab, and then the data is entered, analyzed, and ideally there is a response towards that case, first to the person, but also to prevent more cases in the community. And it's always a report that goes to the next level. And we'll see how that was a traditional way of doing things, where you would report it as a clinician from your level to the maybe district, and then to the province, and then to the national level. But with some of the digital technologies, you will see now that that can go to all the levels at the same time. So important for VPD surveillance is that we have different types of surveillance systems based on the objectives of the control or prevention of the disease. So we have case-based reporting, and case-based reporting is usually for diseases that are not that common. Let's think polio. Let's hope we don't have any more polio. But that's every person or child under 15 years of age who develops an acute flaccid paralysis should be identified and reported, right? And then we also have a case-based reporting for measles, rubella, Japanese encephalitis, maternal and neonatal tetanus, yellow fever, etc. So these are just some examples. And then sentinel surveillance, it's more used for more common diseases. For example, invasive bacterial diseases, such as the pneumonias and the meningitis caused by Haemophilus influenza, and particularly the vaccine preventable type, which is type B, also pneumococcal, etc. And then we also have sentinel surveillance for rotavirus diarrhea, and for influenza as part of a syndromic surveillance of acute respiratory infection. And then we have some combination of surveillance, for example, for the Neisseria meningitis and the different types of meningitis caused by that bacteria. So the surveillance data, depending on the type of data, is how often it's collected and at what level. At the global level, we get and present weekly polio data. So in this map, you see the most recent update of polio, with sadly a case of wild polio already in Madagascar included in the slide. Pardon, not in Madagascar. My apologies, Mozambique. And the other one here in red. And also the many cases of circulating vaccine-derived poliovirus. And then monthly, we have a monitoring of measles and rubella. And then more infrequently, quarterly, and really has been a bit in pause with COVID, sentinel surveillance data for diseases that are preventable with newer vaccines, such as rotavirus and pneumococcal vaccines. I put the link there if you want to see this data, and you can subscribe to these updates too. So the lab is a really crucial part of the surveillance part of the vaccine preventable diseases. Really, we need to make sure that the disease that we are diagnosing, it's the disease we are thinking it is. It's important to confirm, for example, measles. And for diagnosis, you have different types of tests. And then one is to detect that the person has the disease, but you also want to know in early samples, for example, what kind of more specificity about the pathogen. The serotype in some cases, in the case of measles, it's more the diversity and to really understand where it's coming from and how it's progressing. So then it's really important to mention here that the polio and measles rubella lab network have been extremely useful in public health to make sure that we have the capabilities of doing a rapid and quality diagnosis of these diseases, but have also served as platform to implement diagnostics for other pathogens. Here is just an example of the labs in the different parts of the world for polio, for measles combined, and then also some of the labs that serve as reference labs that can do some of the more specific testing, but testing of the type of pathogen and more molecular epidemiology is becoming more common. The important thing here is that we also monitoring the performance of the labs to ensure that the reporting is timely and complete, that there is a proper quality assurance and quality control, and that the labs keep being accredited, meaning that they are certified as meeting the requirements to serve as labs for these vaccine preventable diseases. Just quickly on surveillance, the standards of surveillance have been updated not too long ago in 2018, and they can be found there. Now, digital health. So we talk about surveillance and now digital health and digital health for immunization. Digital health has really come to revolutionize how we work and how we live. And so it can be used for immunization in managing the recording and the registries, the mobile technology to allow us to reach our vaccinators, reach the population, and also transmit information faster. Also, we have new technologies for identification. We have real-time campaign monitoring where apps allow you to track how the vaccination is going in the campaign. We have geographic information systems and geographic positioning systems. We have barcodes, we have multimedia, and all these tools are just tools that can help us work into improving coverage, improve immunization and surveillance data collection, particularly the quality and the timeliness. And I would say the timeliness is quite is very crucial because it's more enabled now with these technologies. And also allow us to follow people individually. And that's really important, again, to be able to match the person who gets a vaccine preventable disease with the vaccination status, and also can serve to help us do studies of vaccine effectiveness, safety, etc. The technologies allow us to do a much more efficient management of vaccine supplies and the cold chain, and also goes for a more efficient management of the labs and our network of laboratories. It helps us do better investigation of adverse events following immunization, analysis and understand whether it's a result of the vaccine itself, also doing causality assessments. Digital technologies can also help us continuing education and doing continuing education and training, and help us doing social mobilization. These are just some examples of how digital health has revolutionized immunization. Moving on, in 2019, the Strategic Advisory Group of Experts, SAGE, on immunization, endorsed a review of what's happening in the data space for immunization. And improving the data quality and use has to focus in interventions across 5 areas. And this is important for surveillance. It's really important to strengthen governance for data generation, use, and for the information systems. It's crucial to focus on the health workforce that generates the data and should be using it, particularly in the case of a vaccine preventable disease, to respond to that case and to prevent outbreaks. Oopsie, it went back too fast. Also, the areas to focus on, it's in aligning all this technology and information systems with the local context and the needs of the immunization program at every level and in every context. So really, it's important to think how these tools are going to come to help people who are working in the immunization program, people who are clinicians, people who are working in health in general, and ultimately also the beneficiary population. Then this idea that we really need to work more to use the data that we already have on immunization and surveillance to do a continuous quality improvement of our processes, of our tools, and our immunization program at the end. And finally, we have gaps in evidence around what get us to good quality data and what get us to use actually this data that we have. Governance, I pause here because it's really an important area that sometimes when we think digital, we think gadgets and we think about apps, we think about technology, we think about mobile phones, but the governance, it's a foundation and usually where things go wrong. So we need strengthening governance with political and will and leadership, with accountability, with better standards and guidance on how to develop apps and tools and make them more user-friendly, and to really have mechanisms to coordinate, share, and have access to the relevant data and information while ensuring the confidentiality and the safety of the people, of the owners of the people from whom we have data. And also we have to have the adequate resource allocation for our digital tools that help us in our processes. Gavi, the Vaccine Alliance, it's developing and it's about to finish its new digital health information policy and priority areas, and it has identified 6 areas of work. And on the right bottom, you have strengthening the electronic surveillance and data exchange for targeted vaccination and outbreak response. So really this idea of capturing the data in a timely fashion, sharing it, analyzing it quickly, and even being able to do more local level diagnosis so that we can, again, reduce the time to respond. Then in the Gavi Alliance, again, they are working on their strategic focus areas. And one of these focus areas is vaccination targeting. And of course, this relies very much on understanding the occurrence of disease, and we need the surveillance for that. So some of the key priorities and outputs here include the validation and distribution of some diagnostic tests. Again, more capabilities and capacities in countries to do testing, that again, diagnostics and the lab being extremely, extremely important. And then more for using this information to make decisions and really make those decisions more database based on data and also more timely. Also to help us understand programmatic approaches to doing things, new ways of doing things, and finally, to bring it all together in an aggregate or in a case-based, ideally, disease surveillance modules that can be helpful to better understand the situation of vaccine preventable diseases. So here, again, we don't want data for the sake of data. We really want to turn that data ultimately into making people healthier and having a better health outcomes. So the digital, again, is the platform to help us do our processes better, to make better decisions, to take more timely actions. So this, I'm just gonna put it there for you to read if you have time. And then moving on to some particular area where digital, the use of geographical information systems really have revolutionized the way we can do things. And it's being used more and more. It's being used for the vaccination part, but also for surveys. It's also better to understand population movements. And in that sense, also it will help us with surveillance in understanding the population movements, for example, understanding clusters of cases, and then help us implement the control measures, for example, targeted campaigns. And of course, it has been extensively used in the polio program. Technology is also helpful for dashboards where you bring all the different pieces of data together and try to make sense of the situation. How are we doing? Again, that's the key question. And then see if what we do help us do better and repeat. So in dashboards and bringing all the data together is really important. So we're going to come back to this slide because here we have different applications of digital solutions. For the person being sick, we, for example, now have telemedicine. For the clinician that is suspecting a case, we have technology that allows to make the judgment with clinical decision support tools. We also have data collection information using mobile devices, for example. And then finally, bringing it all together with much more rapid ways of reporting data and transmitting it. And in a way to bring that data now to all levels at the same time. Before you would have to collect, say, the reports every week and send them, somebody would enter that in a computer, pass that information to the next level and to the next level. So there was a bigger time lag that we have now. just moving on of some examples in Africa. So many countries were used to reporting data to WHO using different platforms, but here there was one that it was EpiInfo based. Some of you may remember, and the data was submitted weekly, and then it was always a bit lagging, as I mentioned. However, now there is a large project ongoing to connect many African countries to the DHIS regional platform. In no way is this an endorsement of only DHIS2. This really means that the platform DHIS2 is being used in the regional office, and it can receive data from DHIS applications, but also from other systems. The idea here is to standardize, again, standards and governance is part of governance, standardizing the data elements that we need to bring it all together and allow us to have the whole story. Then for the diseases that are included in these modules, the countries can choose. For example, you can choose to have these modules for yellow fever, but maybe not for something else that you might already have some sort of system. So this is an important project because it would help us reduce the time and ideally improve the quality of the reporting and the aggregation. There is a digital health data toolkit. So WHO, what we do is provide standards and then the meta information. So any developer in a country can look at this and develop the system in a manner that uses those standards and can the information bring it all together. Again, this is just a standard data toolkit. And then for the aggregate surveillance package, this package is being built and it will help the weekly reporting of these diseases and includes currently 15. And it really accommodates bringing the facility and lab reporting according to the context. So you can really bring the data from the person being sick and that case investigation from the lab of that person. Moving on, it has validation rules and alerts, which is important to ensure the quality. It helps you alert when there are missing fields, when things don't make sense, and ideally would alert you also of potential confirmed cases. So to have alarms to respond quicker to any VPD. Also brings the dashboards, so we can easily visualize the surveillance data that we have. And the idea here is to help us react quicker. So it's really the dashboard, not for the sake of beautiful graphs, but really help us visualize and make a decision if we have to do something when we see something in the data that make us suspect that there's a problem going on. So for AFRO, for the regional office, it has a data warehouse and it's working to bring all the data into this warehouse. So again, the surveillance data can be also cross and triangulated with other relevant information, such as vaccination coverage, such as eventually some other factors. So there is a different module also for vaccine preventable disease surveillance that is case-based. It has been, it's newer, so it has been configured recently. It has some feedback rounds. It's being compared to current EpiInfo system in some countries. All the design is documented, and now it's really in the process of being tested and fine-tuned so it can be made available. This is the workflow with all the data and the logic of the system. Remember that digital, it's a tool to help us do the processes we have to do and make them more efficient. So this is just the workflow out of how data from the person and data from the results of the testing of that person can be brought together and into a system so that we have a better sense of the cases and the cases that get discarded as well. Finally, there are apps for data exchange that allow us to bring data from different platforms together, and facilitate our analysis. Those were just examples. And here is just an example of the metadata packages for surveillance and vaccine delivery that we are working on. Again, to propose standards and bring together, ideally, data from surveillance with data from vaccine delivery. And this is not science fiction. One of the key elements of VPDs is that we really need to understand the vaccination status of the person who got the disease. Unfortunately, most of our systems look like this in terms of the granular data about the vaccination status of one person. It's usually a book with many, many colors, written incomplete with handwriting. In some countries, it's a copy of the vaccination card that then is kept at the health facility. So really knowing if the person is vaccinated relies on finding them in these registries or looking at their home-based record. But as you can see, many of us got vaccinated as children, and then we have no idea when we got vaccinated with what vaccine. So we have a lot of missing data in the vaccination status, which is really difficult then to understand if we are in an outbreak situation, for example, if it's a problem with the vaccine or failure to vaccinate. So moving on, we have, and the technology and the future allow us to go there, is the electronic immunization registries, where we have data about the person. So it's really having the person as the core of the data record with its individual identification, contact characteristics, and really making sure that there is some sort of unique identifier so that it's me and it's not my sister, for example, the person we're talking about. And then data about each vaccination act is added to this registry. So information about which vaccine I get, when, and who gave it to me. It ideally has data of the vaccinator, for example, the date and time I got vaccinated, and which vaccine, ideally with even the batch number. So these immunization registries can be national or subnational. Many are subnational, actually. They can have online and offline functionalities, and they can be just for immunization, or it can be really integrated into electronic health records, or be linked to the civil registry. For example, in Latin America, that's not uncommon to have the immunization registry linked to the civil registry. So the person, it's used with the citizen ID, and that it's allow us to monitor each person, and we know when that person got vaccinated. And this is extremely useful to do vaccine effectiveness and safety studies. This is really old data, but in Latin America, we could see how much better the data was in countries part of the influenza network. So this acute respiratory infection syndromic surveillance, and countries with an immunization registry were so much better to understand if the person had been vaccinated and find the record than in countries without. This is a very recent slide, but in the UK, this linkage between surveillance data and the person and the vaccination status of that person has been used for 27 years. And here it's really useful for doing enhanced surveillance and identify vaccine failures, for example, but also for vaccine effectiveness, understanding uptake, understanding safety. This is an example of studies that are done all the time with data from England, where we can really see the vaccine effectiveness, knowing the people who get sick, and then what was the vaccination story of that person, because that person has a unique number, which is the National Health Service number, NHS number, and you can bring these two databases together, allowing us to do vaccine effectiveness studies with test negative control. Safety, again, extremely useful to have this person-centric digital system, because you can bring and link different data. So you identify a person with a rare condition, and then around them, you can go to the National Immunization Registry and see if they received the vaccine, when they got the vaccine, where they received the vaccine, etc. And the batch and all these other important things. Another use for safety, it's the the tools that facilitate doing causality assessment. And again, thanks to technology, this can be done so much easier than it used to be. And this is just, again, how now WHO has this, getting all this data to really be quick in detecting and investigating safety signals. And these are my two last slides or three last slides. Vaccination coverage really declined in 2020, and we are just receiving the data for 2021, and it has declined even more in Africa. Not in all countries, of course, but in several countries. So what's the problem with that? Well, declining coverage on top of campaigns, vaccination campaign being postponed. This is a picture of May 2020, where most countries in the world had at least one vaccine preventable disease campaign postponed. It's resulting in large immunity gaps. And we really need to be alert to detect these cases and respond. It's a map of the last 12 months of countries with disruptive measles outbreaks. Again, it's a lot of meningitis, a lot of yellow fever. I don't have a slide about yellow fever, but we are seeing these outbreaks already happening after these declines in coverage and these disruptions of campaigns. And maybe the saddest slide of all, just to see the polio slides, having so many vaccine-derived poliovirus cases and some wild polio now. Thank you so much. And you can see all our data there. Thanks.
Thank you so much, Carolina, for that excellent talk on the surveillance and how we can use digital tools to help us improve on being able to understand the epidemiology of the diseases, as well as to guide us in decision making. Excellent. I'm sure there will be some questions that participant will pose to you. So we will be happy to have you and Sarah in the Q&A session, as well as Cheryl, who is going to speak next. And Cheryl is going to speak about the surveillance of VPDs and other infectious diseases, a focus on Africa's capacity during COVID-19 pandemic. Cheryl, over to you, and thank you.
Thanks very much. Ken, I'm just checking, have I got the right screen or have I got the wrong screen here?
You've got the right screen, Cheryl.
Okay, great. And you can see me and hear me?
Yes, I can see you.
Okay, excellent. So thanks very much for having me. My name is Cheryl Cohen, and I work at the National Institute for Communicable Diseases in Johannesburg in South Africa. We're a national public health institute, so we're sort of mandated to do surveillance for all communicable diseases and also provide data to guide policy. And our center is the Center for Respiratory Disease and Meningitis. So COVID falls in that center, but also other respiratory vaccine preventable diseases like pneumococcus, Haemophilus influenzae type B, Neisseria meningitidis, or meningococcus, influenza, respiratory syncytial virus, etc. And yeah, I mean, the topic, the title was really quite broad, and I'm certainly not qualified to talk on surveillance for all vaccine preventable diseases. So really what I'm going to talk about in my talk is just give a little bit of background around surveillance. I think the talk beforehand has already laid the groundwork for that, and in fact went into quite a lot of the details around surveillance and the different types of surveillance programs. But I'll sort of extend that a bit just to talk about specifically the stages of surveillance for vaccine preventable diseases. And then I'll really just do a quick little tour through COVID surveillance and what we do in South Africa, what we have done in South Africa, and what we're thinking about doing going forward, really as a case study to think through some of the issues around surveillance, because COVID didn't start off as a vaccine preventable disease, but now it is one. So we have to think of it in that way. And then I'll end off just with a few slides just about other respiratory vaccine preventable diseases and what we can say about them from our surveillance. So this slide, oh, sorry, hopefully my slides are moving. So this slide just shows you the definition of surveillance, and as I said, the talk before already mentioned this, although I don't think she actually showed the definition. So surveillance, I think it's really critical to distinguish from research, in that it really is an ongoing systematic system for collection, analysis, and interpretation of data. And what defines it, I think, is this ongoing systematic aspect, but also that it's really data to use in the planning, implementation, and evaluation of public health practice. And we often, when we teach it, we talk about information for action. And I think in a way, COVID provided us with a unique opportunity, because we had to set up a surveillance program for a completely new disease. So we couldn't rely on what we've always done, but rather we had to think about what is the best approach to surveillance. So this slide just highlights something again that was sort of mentioned in the previous talk. And in fact, there was even a question in the chat around this, which is the point that the type of surveillance needs to be aligned to the surveillance objectives. So in the previous talk, there were a number of different surveillance programs or type approaches mentioned. So case-based surveillance, sentinel surveillance, syndromic surveillance, laboratory-based surveillance, you have active and passive surveillance. And all of these different types of surveillance are really tools that we have in our armamentarium to monitor diseases, but they all have benefits and disadvantages. You know, and these normally fall into, for example, cost. You know, usually a national program is a lot more expensive than a sentinel program. Sentinel means you only do it at certain sites. Active surveillance, where you look for every case, is much more expensive than passive surveillance, than when you wait for people to report to you. And then syndromic surveillance, where you monitor everybody with a clinical syndrome, is often, you know, more costly and intensive than laboratory-based surveillance. Laboratory-based surveillance is when you only the lab confirmed cases are reported. But of course, laboratory-based surveillance can't be used if laboratories don't normally test for the disease. So for example, flu, if nobody tests for flu in your country, you do laboratory surveillance, you'll get no data. So you might have to do syndromic surveillance. You might have to monitor everyone with severe acute respiratory illness and test them all for flu, even though it's more expensive. Because otherwise you won't get valid data. So really, there are all these different approaches, and they have to be tailored to specific needs. And you can see just here on the slide, for certain diseases like polio and measles, we have to have countrywide active surveillance with laboratory confirmation of all cases. And that's because one case is an outbreak, is a real important public health emergency. And I must say, I nearly had a heart attack when I thought there was polio in Madagascar as well. But it really is bad, you know, it really is terribly sad for us on the continent, 2 countries with wild type polio, and it absolutely reflects the negative impact on our health systems of the pandemic, and I think we all are at risk, and it is very worrying. But without this national surveillance, we wouldn't be finding these cases. And then you can have passive surveillance for certain other diseases like flu. A sentinel site surveillance in invasive bacterial diseases was mentioned. We certainly do this for flu and respiratory syncytial virus. And then you have at the bottom here your epidemiologic studies, which are more things like serosurveillance, etc., which I do have some slides on. And so really, you know, with the outbreak of COVID, we had to make decisions, and every country in Africa had to make decisions. How do we monitor this disease? As I said, initially, it wasn't a vaccine preventable disease. Now it is. Of all these tools, what is the most cost-effective way that we can really achieve our surveillance objectives? Now, when we talk about surveillance in the context of vaccine preventable diseases, there are a lot of different aspects that you might want to monitor. And I think for vaccine preventable diseases, there's three big arms. You want to know the coverage of your vaccine, you want to know the incidence of the disease you're trying to prevent, and then you want to monitor adverse events. And traditionally, when we talk about surveillance in a talk like mine and the previous talk, we're focusing really on disease incidence. But just to mention that there are these 2 other parts which are also very important. And then there's other aspects that are mentioned on the slide that you might want to also go into or discuss. And I think what's really, really critical is that when we think about vaccine preventable diseases and the type of surveillance that we want to do, we actually have very different requirements at the different stages of a vaccine program. So if you look at this graph, you see here that the incidence of disease plotted against the maturity of the vaccine program, and here you can see at the beginning the disease incidence is high. So this is COVID, you know, at the beginning of the pandemic, right? A very common disease, and we didn't have a vaccine, so there was no vaccine coverage. But of course, in that pre-vaccine period, there are things that you need to monitor in your surveillance. For example, you want to be gathering data that should help you, that when a vaccine becomes available, you'll have an idea of who should we be vaccinating and why should we vaccinate them and what's it going to cost and what kind of systems do we need to vaccinate. So there's all these objectives in the pre-vaccine era, and then as the vaccines roll out, and you have the stage of increasing coverage, and that's what we're in now. In most of our countries, you see the disease go down, the coverage go up, and very importantly, and I'm not going to talk about it, but to mention that it's really important, as you start rolling out the program, you have to monitor for adverse events. And of course, right now with COVID vaccines in South Africa, we use the Johnson & Johnson vaccine. The US FDA just last week released an update saying that they're worried about the adverse event of TTP, thrombocytopenia, and they are therefore restricting the use, you know, of this vaccine to only people in whom other vaccines can't be used. Now that type of safety statement coming out of the United States then affects our local vaccine program, and that's where it's really important that, you know, in order to avoid a lack of confidence in our program, because we are using this product that now the US has expressed concern about safety, we need to have our safety data in order. We need to be able to say, in our country, we are monitoring adverse events, and here is the data. You know, the risk of adverse events is not more than the risk of disease, etc. So it's really, really critical to as soon as you start rolling out the vaccine, you monitor the adverse events. And then, you know, so what may happen, and is happening certainly in South Africa, there's a lot, and the first talk was about this loss of confidence in the vaccine, and that can be associated with a drop in your vaccine coverage. It can be associated with outbreaks. In the case of COVID, of course, immune escape or evolution of the virus can also be associated with outbreaks. And then you may have a resumption of confidence. And then for some diseases, and like polio, but of course, you know, quite depressing news right now, but you may want to go to the eradication stage, and then your objectives change. And I think for COVID, really, we've seen a transition from this stage 1, stage 2, and maybe stage 3. And I just will talk a little bit about what we've sort of done and what some of the issues are. So this slide just summarizes some of what I talked to a bit. In the pre-implementation stage, one of your critical objectives is estimate the burden of disease. How common is this disease, and who is most at risk? What are the strains circulating in my countries in order for us to understand, is the vaccine that's available actually going to cover the strains that are circulating in my country? And what's really critical, and I think has not happened for COVID up until now, but needs to be happening right now, is when we do this burden of disease and risk group analysis, we actually need to weigh it against other vaccine preventable diseases. Because in the beginning, obviously, COVID was so severe, it was kind of self-evident we needed to vaccinate. But now, as we move to very high levels of immunity in Africa and a changing epidemiology, we need to be asking the question, you know, what are these vaccines costing, and how does it compare to other programs? Who should we be vaccinating, and how much damage has actually been done to those other programs as well? And how should we be sort of reorienting and prioritizing at this critical stage? We need to define our goals of our vaccination program, and that's very much based on local epidemiologic data, and then decide on a strategy. Are we going to, and for COVID, this is critical, right? Do we vaccinate everyone? Do we need to vaccinate all adults these days? Should we focus on risk groups? How fast do we need to get the vaccine out, etc.? Post-implementation, you need to monitor vaccine effectiveness. I have a few slides on that. How do we monitor vaccine effectiveness and impact? Impact is really in the reduction in disease following a vaccine. For respiratory disease, very hard to show. In fact, the reduction, especially ones like COVID where there's immune escape. Detect outbreaks, modify your strategy against adverse events, and then different objectives as we near elimination, which we clearly know not going to discuss when we talk about COVID, at least. So just I've got a few slides, and I'm going to go through these quite quickly on what we did in South Africa. South Africa was perhaps quite different from some other African countries. But we did follow WHO guidance, we really, countries were being recommended to essentially test every case who has signs and symptoms suggestive of COVID, and then report these nationally. So it was really what was being recommended was national active surveillance. And then there were all kinds of recommendations around quarantine, of infected cases, etc. But I think what we know is that, that was really difficult for COVID. Now we know many cases were asymptomatic, and also the diagnostic capacity in most countries really was never going to be big enough to diagnose every case. And in South Africa, we have a very large diagnostic infrastructure, mostly building on HIV pandemic. So we did have a very big public health network of PCR laboratories for the diagnosis of HIV that were then sort of converted to COVID. So we were in a slightly better situation. But even in South Africa, and I'll show you a bit later, we certainly never were able to diagnose and test anything like all cases. So on the left, you can just see our COVID data. This is testing and proportion positive since the beginning of the pandemic. We've had four waves. This was wild type. This was beta variant, Delta variant, Omicron variant. And right now we're seeing a resurgence with a subvariant of Omicron, BA.4, BA.5. And you can see, I think, and then on the right you have the cases. And I think one thing I just want to highlight is that for this type of surveillance, which is national active laboratory-based surveillance, the cases that you see over here is very much driven by the testing that you see here. And so currently we are having a big wave, in fact, and I can say, and the experience is that this resurgence of BA4, BA5 is pretty much, there's as much disease as there was in the Omicron wave, so this wave, but you see the numbers are much lower. And a lot of this is actually that people are not testing anymore. People don't want to test because they have to self-isolate, they have to pay to test. The government is sort of focused the testing more on severe cases, and so that's a disincentive, and people are just tired, and they see it as a less severe disease, and so for all of those reasons, the testing has gone down dramatically, and then it looks like the cases are low, but that may not be a true reflection, and that's a real potential source of bias, especially when you're trying to monitor cases of mild disease. Which is what this is, and so one needs to be really quite critical and cautious of inferring at all that these numbers of cases are the actual numbers of cases in the country, because it's simply not true. Most cases never get diagnosed and tested, but for trends it's very useful, right? It does show the waves and the timing of the cases going up and going down. So the next slide is hospitalizations, and this, of course, is a much more robust indicator, right? So cases are very much affected by testing, whereas people are being admitted to hospital is a much more hard indicator. And in South Africa, we have fairly comprehensive testing in hospitals. Again, in many countries that might be difficult to achieve. And here you can see the cases in black, and then the admissions in gray and the deaths in red. And this is the classic separation of the cases and the hospitalizations with the Omicron wave. So this is really a reflection of reduced virulence, probably mostly as a result of increased immunity. So we did a serosurvey here that showed 70-80% of people had COVID. And so while we're still having high case numbers, most people are having, well, the disease is not as severe from the Omicron wave going forward, and that's probably largely as a result of immunity, although perhaps virulence of the organism. And so this is, again, national active surveillance, but just to say, this provides useful data to monitor the trajectory, but it's really, really very, very expensive to be testing every single case throughout the country. And we have to be asking the question, is it necessary, in fact, and can we afford to be testing every single case? Just this slide is data from that hospital surveillance program. It's called the DATCOV program. And just to show you the type of information that in this pre-vaccination phase, and this paper was published prior to the availability of COVID vaccines, one type of analysis, and sorry, it's very small, the font, but really the type of analysis you should be using your surveillance program to do in the pre-vaccine period. So this is an analysis of the risk factors for severe COVID in South Africa. And you can't see it very well, but so we looked at all the classic factors, age, and we saw increased age and diabetes and hypertension, all the things from other parts of the world. We saw that those were all really important. But we were specifically trying to focus, and you can see this in this pie chart here, on the conditions that are important in sub-Saharan Africa, but aren't such an issue in the rest of the world, which are HIV and tuberculosis and other comorbidities. And here, we really were specifically looking at to what extent is HIV a risk factor, and TB. And of course, this can be directed to case management, but then when you have vaccines, this type of information really tells you who's at high risk of disease. And if we are constrained in terms of supply, who should we be prioritizing, what age groups and what risk groups? So this is really the type of analysis one should be doing of one's surveillance data. What about deaths? And South Africa is very fortunate. We have a vital registration system. That means everybody who dies in South Africa is recorded on a database, and those data were usually very delayed, but through COVID, we were actually able to get real-time reporting of those data, which normally they were about 2 years delayed. But because of the urgency, they started reporting them in real time. And this is perhaps the most robust data, surveillance data, right, which is more directly measuring deaths. These are the weekly excess deaths due to COVID in South Africa. So these lines at the bottom are the expected deaths that we should see, based on historical data. And then the black line is what we actually saw in the COVID pandemic. You can see just before the first wave really took off, the deaths actually went down. And this is because of the lockdown. And we had an alcohol ban and all kinds of things in South Africa. And so the deaths went down. And then you see with each wave that the all-cause deaths are really going much above what is expected. And these deaths, this gap is the excess deaths attributable to COVID. And this is probably the most robust measure of what is actually going on in terms of mortality burden. So just moving away from sort of case-based type surveillance, what are the other types of surveillance that are really necessary to supplement our program monitoring? And the other part is genomic surveillance. So in South Africa, we have a network, a whole lot of university labs, our institute, the NICD, and other National Health Laboratory Service laboratories that all have worked together to in each of these facilities sequence COVID strains in order to monitor the evolution of the pandemic. And this is just the latest data. You can see February, March, April. In February, the BA.1, BA.2 Omicron variant was the important one. And then you see coming up, and I'll show you it's better in the next graph, these new subvariants BA.4 and BA.5, which are causing the current resurgence, increasing proportionately. This graph is perhaps easier to see. This is just epidemiologic week. And you see here the beta variant, this is Delta, here's the Omicron BA.1, and then you see the current resurgence we see with this BA.4, BA.5 as replacing, and that's this here, replacing BA.1. So genomic surveillance is very, very important to especially for a virus like COVID, to track the viral evolution, because we know that these new variants are associated with immune escape and potentially with decreased vaccine effectiveness. Now, as I've alluded to, this surveillance has been very, very useful. I think South Africa has been very fortunate. We use some of the techniques mentioned in the previous talk, data linkage. We set up feeds that all the laboratories in the country had automatic feeds into our central database at our institute so that we could count every single lab confirmed case. Of course, now that people are using rapid tests at home, that's sort of broken down. But in the beginning, when it was only PCRs, it worked really well. But it's very, very expensive. And the conversation we're having right now in South Africa is it really necessary? What are the objectives really? What do we want to know about COVID? Do we need to diagnose every case? We're not going to be quarantining. We aren't quarantining anymore. I'm sure we'll soon stop isolation. And aren't we really wanting to be asking the same questions for COVID that we do for other respiratory diseases, which is perhaps when does the season start, when does it end, and what are the circulating variants? And could we be doing this, with a simpler or cheaper approach? And so I want to talk just a little bit about our sentinel surveillance. Many of you may be familiar with this. This is the WHO recommended approach for surveillance for influenza and respiratory syncytial virus, which is really sentinel sites either in clinics for influenza-like illness, fever and cough, or pneumonia, we do pneumonia. The WHO recommended is severe acute respiratory illness, which is also fever and cough less than 10 days in a hospitalized person. And of course, the reason we use sentinel surveillance, not national laboratory surveillance for these diseases, is that nobody really tests for them normally. So clinicians will not be testing for flu and RSV to change their clinical management, because they treat empirically the syndrome anyway. So in South Africa, this is a map of South Africa. We have sites in all these different locations. Some are hospitals, some are clinics, and some are matched together. And you can see there's rural and urban and peri-urban sites. And for many years, since 2009, we've been at these sites enrolling people on a syndromic case definition. So with either pneumonia or influenza-like illness, and then testing them for various viruses. When COVID started, we added on the testing for COVID as well. And also then when the vaccine became available, we added on the collection of vaccine history. And these programs are also not cheap, but they're much cheaper than national testing. I don't know if any of you saw the numbers on, but we've tested millions and millions of people in South Africa already for COVID. Whereas, for example, in this program, we do about 3,000-4,000, maybe 2,000 to 3,000 tests a year, right? So it's a much cheaper and more restricted program. And so we've been looking at, could we rather for COVID be monitoring with sentinel surveillance? So this is just the data from our Sentinel program since the start of the COVID pandemic. This is on the left is outpatients, and in the right is in hospitalized people. And you can see it really tracks very beautifully the same that we got from those millions of tests done nationally. And you can see we also sequence all the strains we get, and that's the advantage, right? You're collecting them yourself, so you have them for sequencing. This is wild type, this is beta, this is delta, this is Omicron. So you can see it reflects very well the timing of the waves, and also the different variants that you find. With our Sentinel surveillance, we were also able to do an analysis of the risk factors for severe disease. And you see here increased age, different comorbidities. You see HIV coming up here with immunosuppression in particular. So people living with HIV with severe immunosuppression are the most at risk for severe disease. We see tuberculosis coming up. So a much cheaper program, able to provide really the same type of information to guide our vaccine program, to guide our public health response. And this is really the discussion that's going on right now, is when is the time that we can start transitioning to only at certain sites testing in a systematic way for SARS-CoV-2 as we do for other diseases. I just wanted to show you that you can also use this type of surveillance to measure the effectiveness of the vaccine. So how well is the vaccine performing? And so we, as I said, we collect vaccine history on everybody at our Sentinel surveillance. And if you think about it, we have people admitted to hospital with pneumonia. Some test positive for COVID, some test negative. And in this type of test negative case control design, the people who have COVID are the cases, the people who are negative for COVID are the controls, and then we compare what proportion are vaccinated in each group. And by doing that, you can work out what is the vaccine effectiveness. In other words, to what is the percentage reduction in risk of COVID hospitalization in people who've been vaccinated in our setting. And this just shows again the same figure that I showed you, the Sentinel surveillance, the four different waves. This is when the vaccine was introduced before the third wave. And then we evaluated in the green the Delta vaccine effectiveness against Delta, and here the vaccine effectiveness against Omicron in our Sentinel surveillance. And here you can see some results. The top here is for the entire period. This is for the Pfizer vaccine, the mRNA Pfizer vaccine. 50% protection against hospitalization, but really interesting, when we break it out, we have an 80% effectiveness in that Delta wave, and then a much lower vaccine effectiveness, but very low numbers, so very wide confidence intervals in the Omicron wave. Now that doesn't mean it's not working in the Omicron wave. We were somewhat underpowered to look at it, but there are also complexities in this because there was waning immunity. So many people were vaccinated a lot, you saw, long before the Omicron wave. But also, we have to understand, by the time of the Omicron wave, 80% of South Africans had actually had COVID. And so we're not comparing the vaccine to, we are comparing to unvaccinated people, but we're comparing vaccinated people to unvaccinated people who've actually had COVID. And we know that COVID itself protects against hospitalization. And so it's not the clean playing field that we had at the beginning. And so even the lower vaccine effectiveness we might see in our setting may not actually reflect poor vaccine performance, but in fact that the comparison group has also had so-called natural immunization through infection. I just have 2 slides on serosurveillance. So this is more a supplemental thing. It's not something you do ongoing, but serosurveillance can be very useful for a pandemic disease, because essentially we know prior to the introduction of the disease, no one had immunity. So when you take people and test their antibodies, you know that it's quite specific that they've had the infection of interest. And we did a number of serosurveillance studies. The one I'm showing here is something called First C, which is where we took people and took blood from them every 2 months. So from the beginning of the pandemic, where you can see here, this is a rural site, this is an urban site, very few people had the infection, and then going up to before the Omicron wave, where in our rural communities, over 60% had evidence of COVID, and in our urban site, about 70%. And you can see in the different ages, although it starts off different, sort of towards the end, really everybody has very high levels of infection. And I don't have a slide. We're doing a survey now, and it's well over 90% of people have antibodies in South Africa now. 90 to 97% have antibody evidence of anti-SARS-CoV-2. So essentially in South Africa, everybody's had COVID now after after the Omicron, or almost everybody has had COVID. And very importantly, though, just to highlight in this little box, when we compared, so these surveys were very targeted in places where we had very good COVID surveillance, right? Only 2 to 8% of all lab confirmed infections were diagnosed on a PCR. So what this tells us is that even in South Africa, where we have national testing, and at the beginning there was really free testing for anyone, the vast minority, it's only a fraction of all the testers that are ever getting diagnosed. And so this comprehensive surveillance is really not actually able to properly estimate the burden of disease. Just to touch on other approaches, routine data can be used. Many countries don't have this, but we had a system. It's a busy slide, but you can look at the paper. There's a private hospital group that has an electronic database that monitors all their cases. And so we started, because of COVID, we were able to get a data feed from them. And that can also be very useful because they're very big data sets. And they, this showed us that in children, for example, respiratory admissions really went down a lot. And then in adults, we had these big COVID waves. And one of the big strengths, if you do have routine data, and that's why I wanted to show it, is that you can use health insurance data. If you have medical aids in some countries, you can use that data to actually estimate vaccine effectiveness. So this is a study looking at the effectiveness in the Omicron wave from a much bigger database. And here you can see that while we had sort of lowish vaccine effectiveness in the Omicron wave, they were able to show up to 70% vaccine effectiveness against Omicron, going quite far out. And I think this is because it's a very big data set. The difficulty is there are very few African countries that actually have these types of large electronic data sets. But I think it goes back to the previous talk about we really need to be using digital technologies in a more innovative way to start capturing, because a lot of countries have these data. They're just in books that are sitting in the clinics. And it's how can we use digital advancements to get those sort of paper-based data into databases. So I've got 2 slides just on why it's important, even through a pandemic, to maintain your routine surveillance. One other program we have in South Africa is invasive bacterial disease surveillance for pneumococcus and meningococcus. And in the COVID pandemic, it was really a lot of work to keep those programs going. But we kept them going, and we kept the laboratories reporting. And you can see here that what we saw is what many other countries saw, is that with the COVID restrictions, the invasive bacterial diseases went down dramatically. So you can see here, this is historical pneumococcal disease data. This is in the COVID pandemic. And the same for Neisseria meningitidis or meningococcus, historical data, and this is in the pandemic. And I don't have slides on it, but it really just carried out that as long as the lockdowns and the masks and everything were sustained, we really pushed down the rates of pneumococcal and meningococcal disease, which shows if we were always locked down, we would keep them down, but obviously at too much great societal cost. So, and of course, if you don't understand this can sort of mess up your other surveillance. Similarly, and this is just showing the same for influenza and respiratory syncytial virus. This is the blue is historical data from South Africa. Influenza, every year we have a season, and here's the COVID pandemic, and flu essentially disappeared in South Africa. It's now come back. And the same for RSV. RSV is in the gray, and we had an RSV season, very classically timed every year, and then RSV went down a lot in our lockdown, although it came up much faster than flu. So really what is needed going forward, I think we need to, you know, at this time, I think we're certainly in many African countries, I think we're at a critical time. We need to be thinking COVID is a vaccine preventable disease. And what do we really need from our surveillance to be able to guide our vaccine program? I think certainly for South Africa and perhaps in other countries, we need to be looking at who's at risk for severe disease now. Now that we have high levels of immunity, who are the people at high risk of severe disease? We need to start comparing COVID to other vaccine preventable diseases to really, you know, think of more sustainable strategies going forward. Who should we be vaccinating? And looking at cost and cost effectiveness. We need to have ongoing vaccine effectiveness data to demonstrate that vaccines are working. And then we need to develop priorities for COVID in relation to other vaccines, because we know that the COVID pandemic has really damaged our other vaccine preventable disease programs. I don't really have time, but I mean, maybe one just, so this is an early exercise we did where we sort of compared the burden of seasonal influenza, so in 1 year, to the burden of COVID in the different waves. And, you know, in the first few waves, we showed there was a much bigger burden of hospitalizations and death from COVID. And of course, that's the strong rationale for COVID vaccines to be rolled out. But now, as we move to more immunity and we see that disconnect between cases and hospitalizations, we need to be redoing those analyses to see, you know, today, how does COVID line up against flu, against pneumococcus, against all those other programs or diseases in our EPI program. Just lastly, to say our NICD website has really got all of the data that I've shown you is published on our website, and we produce weekly and daily reports. And so my concluding slide is really that surveillance for vaccine preventable diseases must be objective driven, and it mustn't be static. We can change what we do as our objectives change. You may need supplemental data, for example, serology, to actually understand the ground truth and how well is your symptomatic disease surveillance working. Local vaccine effectiveness estimates are important, but it's difficult to achieve. I didn't talk about it, but it's really quite hard to get enough cases in a test negative platform to be able to really measure performance. And I think the future of respiratory disease surveillance is multi-pathogen platforms and synergies across programs like flu, RSV, and COVID. And we may need to do local, have local approaches that are not necessarily generalizable. And just to lastly, to acknowledge that the data I've shown you is generated by many, many people in different programs, both syndromic and then the NICD national surveillance as well. Thank you.
Thank you so much, Cheryl, and thank you to Sarah and Carolina for the other wonderful presentations. So we are going to move now to the moderated question and answer sessions. And Naina is going to project the questions. There have been very interesting questions asked, and I'll just choose from there for to you. And we encourage the participants to ask more questions. We want this to be as interactive as possible. So Naina is going to project the questions here now. So the first question is from Ludovico Zirimenya, and who says, thanks Sarah for this presentation. Any data on vaccine hesitancy in adolescents, its prevalence, and if interventions you propose are different from what one would use in them? So over to you, Sarah.
Thanks, Charles, and thanks, Ludovico, for the really interesting question. I'm presuming you're referring to data on vaccine hesitancy for COVID-19 vaccines for adolescents, but do correct me if I'm wrong. So at least in South Africa, I'm not aware of research that's really focused on adolescents. All our sort of big surveys and even our qualitative research is really focused on adults, so over 18. So we don't have data really on that. And as it is now opening up really to that population group, but I think it really speaks to a real need for research in that area. What we have there is quite a lot of data on young adults, so not adolescents, but sort of 18 and into 20s. And as I mentioned in my presentation, that group really has been found to have the highest rates of hesitancy. So it does pose implications, I think, for what this could be for adolescents as well. And what we found is some of the reasons are actually very similar for young adults, but just more heightened. So definitely, I think there's a need for more research. Yeah. In terms of the interventions, the broad interventions that I mentioned are and have been implemented in kind of diverse settings and amongst diverse population groups. So I think it does have relevance for adolescents, but I think they would need to, like with any specific group, they would need to be tailored to the specific issues and concerns for adolescents. So for example, the communication strategies, we'd need to have a better understanding of the specific concerns of adolescents to be able to tailor that to them. The same applies for trusted sources. Kind of, we would need to understand who are the trusted sources and mediums for adolescents. But so in short, I think the broad strategies definitely could apply to adolescents, but the tailoring would need to happen. I hope that's answered your question. Thanks, Charles.
Yeah, no, thank you so much, Sarah, and I encourage Ludovico to ask a follow-up question if it comes. So this is still from Ludovico Zirimenya, and this is to Carolina this time. What determines the surveillance method to be used for a condition that is case-based or sentinel surveillance or both? Over to you, Caroline.
Thank you. I think that got really answered in Cheryl's presentation. So really, it depends on the disease, mainly case basis for and common diseases, and sentinel can be more for syndromic or things that are more common. But I think you can refer to Cheryl's presentation. Thank you. Or maybe Cheryl wants to answer.
Okay. Thank you. And like I said previously, Ludovico, you can ask any follow-up questions, just send them to the Q&A and we can take them on later on. So Nina, the next one. So the next one is from Musa Ali. And Musa asks, is there any other option for countries with no national ID? Thanks.
Thank you. So
is this to you, Carolina?
I think so. I think it's for the immunization registries, for the electronic immunization registries, because I mentioned that there has to be a unique identifier for the individual. And some countries have a national ID, and that makes life easier. But many countries with registries do not have a national ID, at least not for children, for example. And what they have done is to combine some other elements, for example, a health number or an ID number given just for the health system, just for the registry, usually combined with like a birth date or some information linked to the mother of the child, if it's a child. So there are options. Those countries usually have more deduplication routines that they have to do to verify that a vaccination record is and a different one in a different time belong or not to the same person when there are, for example, similar names and others. The United States does not have a national ID, and there are immunization registries that are based on each jurisdiction, so states and other big cities. They don't have one, and they have managed with combination of numbers to come up with IDs for a registry. Again, the issue is the having to have more deduplication routines in the data cleaning.
Thank you so much. Nina, do we have another question? Okay, so
yes, also for me.
It's also for you. Yeah, go ahead.
So I think the question becomes how much time it can take to deploy an electronic immunization registry. I think this is a very good question, because even though that's a really good solution, when you have one, it's really helpful. Getting to have one that is mature enough where everybody uses it, where people are comfortable with it, where there are no parallel data entry and parallel systems, it can take a really long time. So in the experience from Latin America, what many countries have one now, it took 7 to 10 years to really have a registry that it's with all the like very, very useful, very implemented by everyone. In the case of Chile, for example, that is one of the best ones in Latin America. They started with the H1N1 influenza pandemic. And so they only started with vaccines for influenza and mostly for adults. And then they added all the routine program, and they added everything. And only about 2 years ago, they have done enough testing to make sure that it's complete enough to have all the population, that they stop any calculation of coverage using alternative denominators, for example. So it can take a long time. However, it's taking shorter and shorter because technology is more available, a lot more experience is out there. But really you have to have the conducive environment. So you have to have the readiness assessment before embarking in a registry is probably very, very important, because if you are not ready, it can, more than time, it can be counterproductive.
Thank you so much for that. And so the next one is for Sarah from Aymen Ayuni Eblabidi. And the question is, I would like to know if there is any evidence-based intervention that has been shown to be effective at reducing vaccine hesitancy for COVID, and what are the research priorities on vaccine hesitancy and confidence? Over to you, Sarah.
Yeah, thanks, Amanda. A very good question. You know, testing the effectiveness of an intervention to reduce vaccine hesitancy is a lot harder and more complex than, well, correct me if I'm wrong, but than testing the effectiveness of a vaccine, for example. These kind of social interventions are very difficult to test the effectiveness. I'm not aware of a RCT that has tested the effectiveness of an intervention to reduce COVID-19 vaccine hesitancy. It's still quite early days, so that could come. Even within vaccine hesitancy more generally, even childhood vaccines that have been around for a long, long time, there are actually very few rigorous intervention studies that have looked at the effectiveness of interventions. So that's a long-winded way of saying not really. No, I don't think there has been shown a single intervention to be effective. So I think speaks to your next question is there really is a need for more intervention-based research in this area, kind of testing the effectiveness of different interventions for addressing hesitancy in different settings. So I think that is a big thing. As I also mentioned in my presentation, you know, research in this area is still really, really lacking in many African countries, and so there's a real need for all different types of research in vaccine hesitancy. So really, we still need to understand the determinants, the prevalence, the contributing factors. I think often research from high-income countries are generalized to our settings, and vaccine hesitancy is so context specific that we really need more local data. So I think there's a need for survey data. As I said, we also need to validate and test different survey tools that have been developed to measure vaccine hesitancy, particularly in the global north, so that we can start using those tools more in our own settings. And then also need for in-depth qualitative studies to really provide contextual data of the complexities of some of these issues. Thanks, Charles.
Thanks, Sarah, and thank you, Aymen. So the next one is still for Carolina. Is there any other options for countries with no national? Okay, we had this. Okay, so it's a repeat from another person.
Those are all the questions that I was able to capture.
Oh, okay. So if there are people who, Kagina, Benjamin, you raise up your hand. Okay. Yes, over to you, Ben.
Thanks, Charles, and thanks to the speakers for excellent talks. My question goes to Cheryl. Cheryl, you did mention about the Sero survey, which is very interesting, and I'm wondering whether you think the Sero survey data is robust enough to inform COVID-19 vaccination policies on the continent. And the second question, Cheryl, is that, and you mentioned that, in South Africa, especially because of HIV research infrastructure, there was a lot that could be somehow repurposed for COVID. And you mentioned how expensive some of these, for example, PCR system it is to keep on going. And I'm wondering whether we're going to have that reverse repurposing where a lot of COVID-19 investment in surveillance or any other activities could be repurposed back to routine, for example, immunization. Thank you.
Yeah, so thanks. I mean, both good questions. So I think, look, the sero surveys, in terms of the robustness, the validity of the data, I think they're very robust. So we did a very intense study in the beginning of COVID, up until after the Delta, so first 3 waves, where we PCR'd people twice a week, and we did serology in them. So we tested them every 2 months on serology, and then but we also took swabs from the nose for PCR twice a week. And what we found is that where you sample people 2 times a week for COVID, there's an extremely high correlation between seroconversion and PCR. So 90% of the seropositive people we also had on PCR, and the other way around, 90% of the PCR positive people also seroconverted. You can't really get better than that, because some people don't get an immune response and you're not swabbing them every day. So there's a very, very strong correlation. In other words, if you use the right assay, in our case, we use the Roche anti-N assay that is sensitive and specific, it does certainly reflect the high levels of infection. And as I said, in our recent survey, which is not published, it's still underway, but we're seeing very, very high seroprevalences. Now, to what extent can that guide vaccine policy? I think, that's sort of taking it a bit further. So if we think of, I think what we are observing is that and we also see it in the disconnect, as the cases remain high, we see the relative severity going down. All of this is the so-called transition to endemicity, from being a pandemic virus to being an endemic virus. And when it becomes an endemic virus, then it's going to be more like influenza and respiratory syncytial virus and those other diseases. Now, in Africa, we hardly vaccinate against flu. RSV vaccines are coming, and when they come, I think there'll be a very strong argument for cost effectiveness. So we don't have that much experience, in fact, in making policy. But I suppose we need to think of it with regard to something like flu. So flu also, if you test everyone, most people will have a seroprevalence. That doesn't mean we shouldn't vaccinate against it. So I think the seroprevalence is important in terms of saying now is the time for us to change our thinking. This virus is no longer a pandemic virus in the sense that it's completely new. And it explains the reduction in severity. And so it tells us we're now in a phase where we need to do where we need to look at the burden of disease and start, in my opinion, and this is an opinion, it's not a, we need to start thinking of it more we need to actually now line it up against flu, against pneumococcal disease, against RSV, and decide what's the best use of our resources. So I think it can be used to guide policy, but it sort of it needs to be with other data in terms of context. Your second thing about repurposing, I mean, that's also a fantastic question. And I think the best example of that is probably in the area of sequencing. So sequencing of viruses, right? There has been an explosion on the African continent and a massive investment. And many, many countries that didn't have sequencing, they now have machines for sequencing, etc. But as the interest in COVID goes down, the samples are coming in less and less. And so we really need to think, how can we build on that? And I certainly hope, because, I mean, hopefully we won't see an increase in polio, but there are many other diseases, polio, measles, influenza, where that type of sequencing can really, really help to guide policy. And so hopefully we'll see that shift. But I suppose it always needs to be tempered with coming back to, why are we doing the PCR? And why are we doing the sequencing? Being very careful to say, what is the public health question that we are trying to address. But I think it's a great opportunity for Africa right now, and to hope that we can really sustain some of it.
Thanks.
Okay, let's see. There are no more questions. I don't know, Greg, did you have a comment, or Rosani? Yeah, Greg. Greg, you are still on mute. Over to you.
Yeah, I just lost the the mute button, Charles. And well, let me just say thanks to the presenters for excellent presentations. today. I had a question, in fact, two questions to Caroline. Caroline, and it's in relation to the data tool usage in, for example, the WHO Afro region. Do we have any idea as to how many countries are using these data tools? And what sort of support does WHO give to countries in terms of the utilization of such tools? That's the first question. And the second question relates to quality of data. You know, the lab surveillance data and the quality assurance is excellent because the checks and balances that are put in place at a local level and then also at a more regional and potentially a global level. But what about field surveillance in terms of quality? Do you have a comment on that? Thank you.
Thank you. So in terms of what each country has, at least in HQ, and I work in HQ, we don't have that. So maybe the regional office might have more insights of what's the different systems that each country use. I do not have that at the global level. What we support, it's really with the metadata packages, meaning really setting the standards of what any information system should include. What sort of the standards for the variables, the standards for if it should be a numerical variable, if it should be integer, if it should be these sorts of things, and really ideally that they are in a way following the standards of the country. So really align with whatever the country has for their own digital health strategy. Many countries use HL7, for example, as a standards. So in terms of the support it's helping countries that want to implement solutions with the standards, and also the DHIS2, because it's so commonly used. We provide the DHIS2 developers with all the specifications, and even for the dashboards and sort of the automated things that the analysis that DHIS2 does, they come pre-coded, right? So for surveillance, it's just now being further developed, as I showed the aggregate, but really the case base, it's still behind, and it's replacing an older system that was based in EpiInfo. In terms of the quality of the data, the quality of the indicators, so each of the different surveillance systems has indicators. For example, for AFP, you have indicators about the sensitivity, at least 2 cases per 100,000, for 10,000, at least how quickly you have the specimen sent to the lab, how quickly the lab results come, what's the percentage of negativity and identification of other viruses, etc. So those are specific for that particular VPD. For measles, there are other indicators for specificity, for the functioning of the lab and all of that. And that's monitored routinely, and it has declined. The quality clearly declined with the COVID situation, where there has been less reporting and of course, massive delays with transportation of specimens, massive delays with the lab being repurposed to do COVID testing and other things. So there is work on improving that again, picking that back up. And I think I'm missing one part of your question. If you could remind me, sorry.
No, I think you've covered all the comments. I mean, sure, in terms of the requirements for the specific diseases that are targeted for elimination, like measles and polio, I mean, there are specific indicators. What about other diseases in terms of vaccine disease surveillance? I mean, is anybody keeping a track on that at a regional or global level?
So the answer is yes, but so those are reportable, notifiable diseases, diphtheria, whooping cough, other diseases are notifiable. So we get that data. Now, how the countries have that system, it's a bit of a mystery, because it's really variable by by country. For example, pertussis, it's a big problem with the diagnostics being really complicated. So we know that pertussis is massively underdiagnosed and also underreported. So at the global level and at the regional level, we collect that information annually. But when we really have to use that data, you have to go understanding many of the caveats in terms of underreporting and problems there. Tetanus is particularly underreported for particularly neonatal, because babies die in the first few days and nobody knows what happened with that baby. Nobody knows that that baby existed because it never got, that birth never even got notified. So in many of those cases, there are field studies done. For example, if you want to document elimination of neonatal tetanus as a public health problem. And in those cases, there is a lot of more active search in files, etc. But it's substandard. I mean, we clearly have underreporting for most of our VPDs.
Thank you so much, Greg and Carolina. I saw there were two hands from Paul Baloye and Rosani. They have put them down, but I will still want you to talk, Paul Baloye.
Charles, I thought Mpo should go in first because mine was a comment, but I thought Mpo can go in first as he had a question, it seems, for Sarah.
Okay, Mpo, over to you.
Thank you very much. Am I audible?
Yes.
All right, I just wanted to find out, we seem to have seen a change when we conduct our outreaches, you know, to try to mobilize the communities from vaccination. Then we realized now there's a strategy that is being used. I think it's in South Africa right now, as Wakala, when they have using systems such as loud music, you know, it happens to have an impact on the communities. You know, they respond better. And we just want to find out, how is this possible? Is there any research that has shown why is this having an impact? Is it because they are being entertained at the same time, or what could be maybe the reason behind such a better response as compared to when we just loud hail and give people important information and we ask them to come over and get the vaccine, you know, which is brought closer to them, but they respond different as compared to when there is a loud music. Thank you so much.
Thanks, Mpo. I mean, an interesting question. I mean, my response, I don't know. My response would be it could relate to what I spoke about a bit of the kind of positive social messaging and positive forms of communication around vaccination. What does seem to be coming out is people respond more to kind of feeling when we are positive about vaccination, when we applaud people, when we celebrate, when we congratulate people for taking the vaccine. So all the kind of, as a communication strategy that's uplifting, exciting, fun, nice, and positive, it seems to resonate for people a lot more than if it's more punitive or encouraged in a way that's more disciplinarian. So my response would be, I mean, it's something that would be interesting to study, but my response would probably be it's related to that. It could be related to that, of that kind of the positive, bringing out the positivity of vaccination. You're even seeing it with the kind of communication. They've shifted from quite serious providing facts of how vaccines work to fun cartoons and making people laugh and the enjoyment around it, which I think resonates for people. So maybe loud music and a feeling of entertainment and this is fun forms part of that. Yeah.
Yeah, thank you, Sarah. I think during the next webinar, Ben should bring some loud music for us for the positive messaging around vaccination. And I see that Paul agrees. So over to you, Rosanne.
Thanks, Charles, and thanks to everyone for very, very, very good talk. Sorry, I'm sitting like this. I'm trying to recover from COVID-19 from home. Thanks, Cheryl, for the surveillance. I just wanted to point out that it's very interesting that whenever you talk about the issue about surveillance and data on which decisions and policy have to be made, to be informed on, the lowest level of investment for countries, and in particular, this is an area where donors don't seem to be very much interested as a general rule, is the area of surveillance. And quite often it's so easy in terms of understanding whether a vaccine is effective or has got high enough efficacy or whether it's relevant, as long as you can marry that with epidemiology, which is always local. So whenever you look at WHO position papers, whenever you look at advisory from SAGE, for example, they're very robust and very solid, given the evidence that someone has done a study somewhere in the world that shows that the vaccine actually works and will make a difference. But when one has to make a decision for a local level, say, for example, in ITEC, what matters is whether all that known great information data actually applies to your context. And without that surveillance data, it's so difficult. I mean, even here in South Africa, where we're much better than a number of countries within the continent, now and then something comes up. You want to introduce a vaccine at one stage or another. You sit there, you just don't know whether this is appropriate. And the reason for it being appropriate or otherwise is what the epidemiology of disease is and what you're trying to achieve with that vaccine. And I'm just not sure if there is any way forward in which support for the work of vaccines and vaccination can go beyond first of all, I mean, the primary area is just giving money for doses, irrespective of what you do with the infrastructure for vaccination, which I think is probably more expensive than the doses for most vaccines. But there are efforts to try remedy that. But the surveillance part, I found that is an area where the investments are the least, but you can't make a decision without doing that. Either thumb suck it and just says, well, there must be a lot of people with this problem, and so we just need the vaccine, but you can't monitor the impact of your vaccine because there is no baseline and you don't know what you're. So I'm just putting it out there and to emphasize the importance of how significant and important in decision making and in policy formulation contextualized surveillance is for a generic, what may seem like a generic intervention. It has to have contextual relevance. Thank you.
Cheryl, you can respond. Thanks.
Well, I think Rosani makes an important point, and I think, even Gavi, they fund the vaccines, but they don't necessarily fund the surveillance. I think, just one thing is, and I do think it's a potential opportunity offered by COVID, is there are certain types of surveillance that people do fund. So one is influenza. So especially on the African continent, a number of countries have received funding from, often the US CDC is the main funder to do sentinel surveillance for influenza. But of course, influenza is an important problem, but it may not be the most important problem in your country. And what we did with our influenza surveillance was we said, yes, we'll do influenza surveillance, but you must let us test for respiratory syncytial virus at the same time. Now RSV is a much bigger problem in most African countries compared to influenza. It's the commonest cause of admission in children, and hospitalizations in children for pneumonia is the biggest problem or cause of hospitalization often in that age group. And that was sort of an opportunity, because now actually we have data that shows if we get a vaccine, it will be cost effective, right? I think with COVID, there will be donors wanting to fund pandemic preparedness type surveillance because they'll be worried about respiratory diseases emerging in Africa. And so I think we do need to be strategic. If there are funders who are willing to support sentinel surveillance or other types of surveillance, to really try to sort of tag on what we think as our own in-country priority. It's not always possible, and it might be the wrong type of platform, but that's one type of thing. And then I think the other part is really, I suppose it's pushing it also with somehow for the NITAGs to push back to the government to say, well, you know, if you're going to pay for this vaccine, you actually need to invest in the monitoring. Otherwise, we're never going to be able to tell you if you're getting value for money. So, but of course, it is difficult in a resource constrained situation.
Thank you so much, Carolina.
I also want to add that it's true, and I don't understand why either, in the sense that I've been trained in public health, right? I started in the US CDC. Surveillance is at the core of everything we do. So when you always find these barriers towards funding, it's a little surprising. And I think one of the factors is that it really needs to be sustained, and that takes a lot of effort, and not only money, but really keeping hospitals, for example, engaged with surveillance of invasive bacterial diseases, engaged with surveillance of some diarrheal diseases. It gets you to train people every time. It gets you to have the whole process be running, having the quality assurance and quality control frequently. So it's not a one-time investment. It's really an ongoing investment. And I think that the idea there of capitalizing on integration and being opportunistic, it's also really, really important. And many countries just frame this as global health, safety. It's not even about the people in those countries. They just fund it because it's a global health security. But I also come from a country from the global south. We need to take advantage of those opportunities whenever they come and make the investments in a strategic manner so that we can keep our systems working for us for what's also very relevant to our countries. I come from Chile. Respiratory syncytial virus, it's the big problem there. So it has always been integrated with other diseases.
Thank you so much, Cheryl and Carolina. There was a comment from Ashley. Professor Kulane, do you want to make that comment?
Thank you. Thank you very much for this opportunity and the session. Thank you all presenters for insightful and excellent lectures. The question is actually for Sarah. Sarah, I wanted to ask you, we commonly know that all vaccines have been for children, and introducing new vaccines has been quite common. However, now with COVID-19, it targeted mostly adults. And my question is based on, all these challenges we see with vaccine hesitancy or low acceptance. Is it due to because we have a new group that only vaccinates, perhaps only for traveling purposes or so on? And could you reflect on this in your experience? What would it have been if this was targeted for children and we approached it with all the systems we have in place on how to distribute childhood vaccines and not much hesitancy from the parents? So I want to tap on your experience. Thank you.
Thank you, Ashley. Sarah?
Thanks, Ashley. A really, really great question. And I think, at least from our research and others that we're seeing, this has been a real thing. There just, as you say, there isn't a culture of vaccination amongst adults, and the systems for vaccinating adults are just not at that level of routine like with childhood vaccination. I think this has been a big thing. We are asking for a kind of quite new and behavior from a lot of adults that don't normally have to do this and don't. I mean, even in a lot of our context, influenza vaccine hesitancy, uptake is very low. And so some of the common adult vaccines it's not a culture of it. So yeah, I think you raise an interesting point of if this had have been that we were needing to vaccinate just children, kind of whether that would have been smoother and easier to do. I think it also raises the thing of vaccine hesitancy and what makes it such a slippery, complex sort of thing that one can't address with a one size fits all, that with each population group, whether it's we find specific issues, and so that almost has to be addressed separately and in different ways to what would maybe be addressed for adolescents or other adolescent vaccines or routine childhood vaccine. There are many. Vaccine hesitancy is not one singular thing, which makes it complex here. But yeah, very good question. Thanks, Charles, and thanks, Ashley.
Thank you, Sarah. And let's see, well, the presentations have been quite comprehensive and also this discussion, but I don't, the participants, yeah, Nina has told me that they are not sleeping, they are all there. It's just that there are no additional questions, but do you, okay, Ben, over to you.
Charles, it's a question to Carolina. Carolina, in your presentation, you mentioned about the DHIS, the regional warehouse, and you said that there's work that is ongoing to set up. Could you please expand more on that, especially in the African region? And also in terms of the access to this data, is it open access when complete? And if one wants to know more about, accessing this data, what are the mechanism? And then related to that is also the issue of data protection, which often comes when it comes to digital surveillance. Just want to know whether there's a framework to take into account data privacy. And then lastly, the issue of GIS, which is very interesting. And I think some countries are able to use it, especially for contact tracing. What's your reflection in terms of using GIS for routine immunization or surveillance in that case? Thank you.
Thank you for the questions. So DHIS2 is just an open platform that it's supported, and it was developed and supported by the University of Oslo. And they just offer it to the world as a public good. So it's that's why it's used in so many countries. And because it's used by so many countries, what gets added or adapted by one country is really useful for the other countries. So that's why some of the documents that we put as recommendations get implemented in the packages of the metadata that goes into the DHIS2 applications for routine immunization, for example, for aggregate reporting of doses up. For surveillance, it's right now it's a project ongoing to see if the module for the different diseases under surveillance can be really useful for countries. So it's being tested. And at the same time, there's a project to have the regional database in DHIS2, which makes it easier to bring the data, but the data can come from any other format. So if you have a system in, I don't know, a SQL database in your country with whatever platform in the front end, doesn't matter, because there are all these specifications on how the data can be transmitted and what fields you need and how to translate that into the fields in the database. So a lot of work is going on there to make it easier, both to, if you don't have a system, just to get DHIS2 if you choose to do so, or if you have a system, to have the outputs really be able to feed the regional database. In terms of data security and data access, that is really, really important. So WHO, we have governing principles of data sharing, data access, confidentiality. Most of the data, it's anonymized at the point that is shared after, right? Because at higher levels, you don't need the name of the person who got the disease. You only need sort of the identification of that person if you want to merge data sets and to merge that person from one database, say a hospital database, with the vaccination status in a registry. Then you want to know that that person is for sure the same person. But after those data get transferred for aggregate monitoring, you don't need that detailed information. So most countries in their digital health strategy, they do have all those parameters very, very well determined there, who has access, and most of the systems have different levels of permissions to different users. And then you can make the different type of user, eliminate users after, for example, somebody leaves the health system. So there are really important work ongoing there to ensure the safety of the data as well. So you don't want to lose the data, or you don't want it to be cyber attacked by who knows who. So all that is well normed, sometimes not so well implemented in the different places, depends on the capacities to implement, and is rapidly changing as well. So new technologies, new cyber attacks, so everything has to be quickly updated. And also we're managing massive volumes of data, so that also has to be taken into account. For the access to all these things, everything we receive in WHO, and I speak for headquarters, it gets published on our website. So we don't aggregate. We don't usually put the data country by country, except that what has come to us through the under this data sharing agreement that comes with what data we collect annually, and the surveillance data that we collect, be weekly for polio or be monthly for measles, for example. So you can, I think in my slide, I put the link to our data, and you can access the data as a CSV file, for example, and you can filter by countries and regions and other things.
Thank you so much, Ben and Carolina. I just wanted to follow up on the comments made by Ashley about us having a new a new target group, a new vaccine. And Sarah, just thinking about another vaccine that is relatively new and maybe a target group that is also relatively newer than the childhood vaccination, HPV vaccination. Do you think there has been what would you say has been might be the impact of COVID-19 on HPV vaccine confidence or hesitancy, and any other information you might share about that newer vaccine and new target group? Over to you, Sarah.
Yeah, thanks, Charles. It is an interesting question, and I think we are seeing kind of spin-offs and back and forward impacts on different things. I mean, at the moment, we actually doing a Cochrane review looking at acceptance and the factors influence acceptance of HPV vaccination for adolescents. And I mean, it's still early days, and we're seeing the findings emerging from that. But there was similar kind of things with that vaccine around it being a new vaccine and a new target group. Yeah, very similar kind of things. We also are seeing the impact of COVID-19 vaccine hesitancy is affecting other vaccines. So it's kind of, in some cases, exacerbating more general vaccine hesitancy and sort of anti-vaccination trends in the country, including for example, HPV vaccination, but also in terms of for other vaccines, including more routine vaccines. So for example, in some of the surveys that we've reviewed, we found that beliefs in the kind of serious health side effects of vaccines and also preferences for infection-acquired immunity have actually increased since the pandemic. So these kind of beliefs in relation to other vaccines have kind of been exacerbated. So we're seeing this kind of interacting relationship relationship between the pandemic, COVID-19 vaccine hesitancy and vaccine hesitancy more generally. So yet a kind of another reason that we really do need to address vaccine hesitancy for COVID-19 vaccines so that we don't see it kind of spiraling into other vaccines. Yeah, thanks, Charles.
Thank you, Sarah. So Ben, before I hand back over to you, I would probably just go around again to the presenters, starting with Cheryl, then Carolina, and then back to you, Sarah, if you have any final comments, and then I will hand back to Ben. Cheryl? Mm-hmm.
Hi, thanks. I mean, I think, yeah, it's been a great seminar. Nice to hear all the discussions. I think the one question I thought was really important was the one about adults and COVID vaccine. And I think that's a real thing, but I think there's a lot adult vaccines that are coming, you know, so I think we really do need to sort of do more work to understand what are the obstacles to adult vaccination. Certainly flu is in the same category, but you know, there may be future vaccines. And I think, I don't know, from my own perspective, you know, when you're thinking about your I think people, when they think about their children, they feel like they have to look after them and protect them from everything. And there's a very high acceptance because many people have seen the positive benefits of vaccination and the reduction in diseases. It's visible, and there's all that, you know, the impact is actually visible, I suppose. And it's much more difficult with respiratory vaccines in general, right? Because the respiratory diseases don't disappear. And so I think we really need to think about adults, and I think that's an important theme going forward. But thanks so much for having me.
Thank you, Cheryl. Carolina?
Thank you. Well, thank you so much for having me. I'm really happy to be in this session. And I talked about digital, but I really am a public health person. So I really believe in surveillance. I really believe that we should be using the data we have and that we collect, and we can do better. Thank you.
Thank you so much, Carolina. So, Sarah?
Yeah, thanks, Charles, and thanks, everyone. I really, really enjoyed this interaction, and great questions. Got my mind thinking also on some of these other important issues and different research things that we need to focus on. The same thing as Cheryl said, I've also the ticking in my mind of adults here, and we've got a lot of work to do around that, particularly with the COVID vaccine, if there's going to need for boosters and more boosters and an ongoing around vaccination. So yeah, thanks very much for the engagement and discussion. Thanks, Charles.
Yes. Thank you so much. So thank you, Cheryl, Carolina, and Sarah. And thank you, VACFA, for offering us this opportunity. And then I'll hand back over to our boss, Dr. Kagina. Over to you.
Charles. Just to say thank you so much to the speakers, Sarah and Carolina and Cheryl, much appreciated. And of course, Charles, thank you so much for excellent chairing. And we hope that in the future we can count again on you. You've been excellent. And this is really what we wanted, this kind of speaking engagement. And also thank you to the participant for tuning in. And as a continent, there's absolute need for vaccinology expertise, and also try to build a community of vaccinologists within the continent that we can share with one another what are the challenges, some of the lessons learned, and really try to push the continent up in terms of many immunization indicators that are at a level that we all agree we shouldn't be. And to just acknowledge Pfizer, who have given us an unconditional educational grant, and we've had some engagement with them. They had a speaker who was supposed to speak about the new vaccines in the pipeline, and for logistic reasons, they were not able to have a speaker talk to us today, so they sent apologies. And finally, to the VACFA team behind all the planning, comprising of Nena, Edina, and also Salim and Chantel, just to say thank you so much for working in the background to make sure that everything goes smoothly. And our next webinar, I think, which is the last one, is on, I think it is next Friday. Let me just have a look. That's correct. It is next Friday on the 29th. And this is going to be very good because it's going to focus on human-centered design, which is sort of like innovative way to look at regional challenges with regards to immunization and how we can be innovative in addressing some of these challenges. So with that, thank you again to the speakers and to the moderator, Charles, and to all the participants. We thank you for your support and questions. With that, have a good day and have a good weekend. Thank you so much. Bye-bye.
Thank you, everyone.